You've just been told by your veterinarian that your horse has Cushing's. More correctly, we call it Pituitary Pars Intermedia Dysfunction. On today's show, we talk to Dr. Diane McFarlane from the University of Florida. Dr. McFarlane has made her career out of researching this condition in horses.
So in a high sensitivity test, you're going to have false negatives.
We talk a little bit about her background and what led her to become interested in this condition in horses. Dr. McFarlane describes the condition, what it does in the horse, how it appears in the horse, and deals a lot with the vagaries of definitively diagnosing this condition, and talks about the limiting of the testing that we have currently available. We talk about treatment and the relative efficacies of the things that are used now and the things that have been used in the past. Welcome to Stallside. We'll be back after this break.
Stallside Podcast is brought to you by Rood and Riddle Veterinary Pharmacy. As partners in your animal's healthcare, we strive to bring you the highest quality medications, including custom compounds, that are formulated and produced right here in our pharmacy. Along with medications, we also strive to bring you high quality and relevant information, such as that available here on the podcast. So if you like what you hear and see, be sure to refer us to your friends, and remember to hit that like button and subscribe to our channel. We've done a lot of great episodes already that you may need to catch up on, with more just around the corner. One last reminder, nothing you hear on the podcast should be construed as veterinary advice, which should only come from a veterinarian with whom you have a relationship.
Welcome to Stallside Podcast.
Okay, good to go. Dr. McFarlane, welcome to Stallside.
Thank you.
It's great to have you here. So, Diane, tell us a little bit about yourself.
Well, I started off my veterinary career at UC Davis, and I went from there to an internship at the University of Georgia. And that was quite an experience. Many of people who have gone through there have gone on to do very fabulous things. So I was very fortunate to have the opportunity to be there. I went into private practice for a while after doing the internship because that was my initial goal, was to be a practitioner. And so I practiced in South Carolina for a bit and then decided that I really was interested in going into internal medicine. So up to North Carolina State I went and studied there. And during that time, I became very interested in old horses. I had an interest in neonatology. But at North Carolina, we saw maybe 40 foals a year. And so it wasn't really a great place for doing research projects on foals because so many more foals were being seen at Florida and Kentucky. So I got interested in the older horse and did a few small research projects there as a resident. Left North Carolina State, went to Florida into private practice again, but it didn't take. I ended up going up to Prince Edward Island, Canada, and working there for 5 years. At that time, I was a large animal clinician as well as did my PhD. And that's when I started studying endocrine disease in horses. And so my thesis for my PhD was on equine Pituitary Pars Intermedia Dysfunction, PPID, also known as Cushing's disease. After I left there, I went to Oklahoma State, where for 16 years I did research on equine endocrine disease and equine aging. And just this past December, 9 months ago, I came to Florida, where I'm now in the Department of Large Animal Clinical Sciences, where I'm the chair and continuing on with my research here.
Well, look, you've worked in
some great places. It makes me sound old, doesn't it?
No, not at all. I mean, you've worked in some really good places. You've seen some great parts of the country. And, to pick up on that point about seeing aged horses, because even here, it's a breeding area, but we're actually seeing more and more aged horses because as the care's got better, horses have last longer. And you picked up on Cushing's, which, we'd like to talk to you about today. So why is it called Cushing's and what is it?
Well, I don't call it Cushing's. It was originally called Cushing's because there are some similarities to the condition to what we see in dogs and people that have Cushing's disease. And Cushing's disease has a very specific definition. It refers to high cortisol concentrations in the blood. And that cortisol, that stress hormone, will cause things like frequent urination and excessive drinking, so PUPD. In animals, it'll cause changes in weight gain, it'll cause immunosuppression and secondary infection. And then you get the central obesity that goes with it. So that's Cushing's disease. But Cushing's disease has a very specific pathology, and it is not the same as what happens in the horses. And I'll show that in a minute. So the better name for it is equine pituitary pars intermedia dysfunction. And since that's quite the mouthful, we call it PPID. And I didn't coin the name. It was actually the first time I remember seeing it in the literature was in Noelle Dibdahl's papers from 1994. She was a pathology resident at UC Davis, and she wrote a very excellent paper about how to diagnose PPID, and she called it pituitary pars intermedia dysfunction because it's really descriptive of what goes on in the gland in this condition.
And that's a good thing to pick up on too, because I think we do confuse people when we talk, well, does my horse have Cushing's as well? It's PPID. And it's great that you brought out the parallel in that dogs and people are sort of like one pathology and horses are a little bit different. And I think that's, people want to try to sort of equate them, but they're not sort of exactly the same. So say I was a horse owner and my veterinarian said to me, your horse has PPID. Why should I be concerned? In your clinical observations and the research you've done, what's going on and why is this important to the horse?
Okay. Should we start with the what's going on as far as...
Yeah.
Okay.
Yeah.
I'm going to share my screen, hopefully. I'm going to start with a little bit of sciencey stuff, if you will. I'll tell you a little bit about what actually goes on in the pituitary gland in horses with pars intermedia dysfunction. And this first slide shows up here. Do you see my cursor as well?
Yes.
Okay, super. This is a section of a horse brain, just cut right down the middle. And right here at the bottom is the pituitary gland. And above that pituitary gland, where the arrow is what's called hypothalamus. And it's the hypothalamus's job to take all the information from the body and kind of coordinate it and then send signals to the pituitary gland. And the pituitary gland is called the master gland. It sends out a whole plethora of hormones that regulate things like stress, metabolism, reproduction. And so it's getting feedback from the whole body into the hypothalamus, and then the pituitary sends out hormones that go to all different parts of the body to respond to the events that are going on. So this is then a slide that's made of the pituitary gland. So it's actually been cut in half and stained so we can see the different sections. And there's actually 3 lobes to the pituitary gland of the horse. And this little blue lobe is the intermediate lobe. So in dogs and people, when they have Cushing's disease, they get a tumor that occurs in this pars distalis, this anterior lobe. But in the horses, they actually have abnormalities of this little blue strip, the intermediate lobe. And different hormones are made in these different areas. If we go then to just a cartoon, the blue cells then are our pars intermedia. We've got actually neurons that come from that hypothalamus in the brain, and it regulates the output of those hormones. There's another factor besides for the dopamine that's being released from the neurons called Trh, and we'll come back to that when we talk about testing, and that causes release of the hormones. Dopamine from the neurons inhibits the hormones. So you have 2 sides. You've got these cells. They're regulated by the dopamine from the neurons from the hypothalamus, and they're regulated positively by Trh. In pituitary pars intermedia dysfunction, it's exactly what it sounds like. It's dysfunction of this pars intermedia, and it's caused by these neurons degenerating. So it's an age-related neurodegeneration, just like we have in people, similar to something like Parkinson's disease. When you don't have dopamine, which inhibits the output, there's no break anymore. So those hormones just are released all the time. And those hormones then are released into the blood, and they cause a whole series of clinical signs.
That's an excellent description of what's going on. So this clinical signs that occur downstream, how these manifest and what do they mean for the horse?
So let me just stop for a moment and we'll chat. So the different clinical signs that we see, the most pathognomonic is the word we like to use in veterinary medicine, but the most specific clinical sign that you'll see is a change in the hair coat. And so those of you who've been around old horses probably know a horse that stops shedding and it gets that long curly hair coat. And when it looks like that, everybody knows it has PPID or Cushing's disease. That's clear diagnosis. Earlier on, you may notice that they're a little slow to shed. So they may be the horses that in the spring, everybody else is all nice and shiny and their coat's still a little bit wintry, or maybe they still have a little bit of hair left on their lower limbs. The chin, they like to keep a beard for some reason. So you'll see the chin maybe doesn't shed out as well. They also start to atrophy muscle. And we'll see this mostly along the top line, where they start to lose some of that muscle mass. And that is because the hormones that are released from the pars intermedia are very involved in metabolism. And those hormones actually cause weight loss. And so you'll see the muscle atrophy along the top line. These hormones also are immunosuppressive. So we can see some secondary infections. Rain rot is one that you'll see a lot. Sometimes you see abscesses, like hoof abscesses. I had one horse that was in my herd that I collected that had a brain abscess. We've seen Corynebacterium in horses associated with it. So abscesses and bacterial disease seems to be very common in these horses. There's a whole list of things that are not specific, but occur more often in horses with PPID, and that includes laminitis. It includes PUPD, so drinking a lot and urinating a lot, failure to sweat or sweating too much, so any kind of a sweating problem, exercise intolerance, problems with suspensory ligaments. So there's a whole slew of things that can be affected by messing up the hormone balance in these older horses. But what you're really looking for, and then I need to throw in also infertility. And so what you're really looking for is that you have a horse that's aging, but you notice that they start losing their muscle mass faster than the average horse that ages. They start looking a little less thrifty. They potentially are getting some secondary infections. A lot of people say, oh, just old is part of the aging process. But if you really pay attention, they aren't aging well. And so that's kind of the first clue that this might be a horse to test.
You know, you brought out some great points there, because these are a lot of subtle things. And I've had, when I've talked to people about PPID in their horses, and they sort of say, well, how can this be? It's thin. It's not got excessive body condition, and they can't get their mind around the fact says, no, you know, they're actually catabolic, and that muscle along the top line is a classic. I mean, you have this horse come in, it's reasonably conditioned, the coat is subtly not right, like you talk about, and they've just got no top line. And they've been pouring the feed to this horse and been doing all of these things to change it. And you sort of said, well, no, actually, that's a pretty classic subtle sign of this condition. You mentioned about testing, and I think that's something that we all struggle with, is having a test that we can sort of say, yes, this proves the horse has PPID. People like a number, people like yeses and nos, but it's not that way. So walk me through testing and your approach.
So I think it's important to recognize in any test that you do not have a test. There are no perfect tests out there. So that's the first thing. The tests have what are known as sensitivity, specificity, positive predictive value, negative predictive value. Those are all big terms, but the one that we can all wrap our head around is accuracy. Accuracy is how often when you do the test is the answer right. So the way we do it mathematically is we say the horse truly had disease and it tested positive, or it truly didn't have disease and it tested negative, and we add those together and we look at how many tests we've done. And that tells us the percentage of the time we're right. So we just did a big study, and just did is kind of funny because it actually took me 20 years. So I have been collecting samples for 20 years, basically since I was up in Canada, of any horse that I could get that was ultimately going to be euthanized and go to necropsy. So there were horses going to necropsy for other reasons, but if it was possible, I got a blood sample from them, and then after they were euthanized, I was able to get their pituitary. And I've been saving those for 20 years. And we've gone back and looked at the pituitaries as more or less our gold standard. So that's the true deciding diagnostic test if they had the disease or not, is did they have an enlarged abnormal tumor in that intermediate lobe, have disease? Is their intermediate lobe normal? Didn't have disease? And what did their ACTH look like? And we use that to try to predict how good that test is. And in that circumstance, I'm just checking my numbers so I don't tell tales. I did not put it down there. It was about 70 or 80% accurate, somewhere in that ballpark, which means that 20% of the time that test is not correct. So what's very important is when you do testing in endocrine disease, you can't do it in a perfectly normal horse. And I have some really scary math I can share to make this point. And I'm really kind of afraid to do this math with, because it's confusing when I try to teach the vet students, and they've already had a whole class in this, but we'll see if we can't walk through it, because I think at the end it makes a pretty good point. So I'm sharing my screen. Okay, so the scary math part of the talk, are you seeing that?
Yes.
Okay. So as I mentioned, we determine how good a test is or isn't by doing these different statistics. Sensitivity tells us if a horse is positive, will it test positive? So if you have a really high sensitivity, you don't miss any of the positive horses, but a lot of the negative horses might test positive. So in a high sensitivity test, you're going to have false negatives more commonly. Specificity, if you gear your test to be highly specific, if the horse doesn't have it, it's going to test negative. The predictive value sort of takes those numbers and puts them in a situation. So it says, if the population has lots and lots of positives, a positive means more. And so I'll show you that mathematically in a minute. So in other words, if there's only one positive horse in 10,000 horses, and you go out and you have a test that's only good 80% of the time and you get a positive, it's more likely it was that statistical anomaly than you found that one horse. So that's what predictive value tells us. How strong is that test in a population? And then accuracy, as I said, was how well the test predicts disease overall. Oh, here's the number I was looking for. So when we did our study in over 200 horses that I had pituitaries on, so a gold standard to look at, we were accurate about 70% of the time using ACTH as resting ACTH as our test. So that's not fabulous. It means 30% of the time you're wrong on this test. If you look in the literature to see how it performed in the literature, most of the studies where they try to say, how good is this test, they compare to clinical signs. And using clinical signs, the ACTH concentration had a accuracy of 80%. The reason that probably is clinical signs are late changes, and we could talk about that in a minute. So it's a little bit better in this population. We'll talk a little bit later about Trh Stimulation Test, but that one does perform better than just measuring ACTH, and we can circle back to that. But the point being, somewhere between 20 or 30% of the time, measuring ACTH does not predict what's going on in the horse's pituitary. And so you get a false positive or negative. So the point is, you don't want to overinterpret the test. You really need to look at clinical signs and kind of develop a profile, a whole picture of progression of this animal over time, what it looks like now, what the weight is doing, as well as the diagnostic tests. So here's the math that's scary, okay? Are we ready?
Yeah, we're ready.
So if we say that the ACTH, measuring the plasma sample, has a sensitivity of about 80%, and we use it in a population of horses over 15, it's estimated about 20-25% of horses over 15 have PPID. We can argue that number, but we'll use it for the example. That means that 57% of the time, this test is correct in identifying a horse as positive. But if we use it in any age horse, if we use it in young animals, the prevalence of PPID is very low in any age. So it's between 1% and 3% if you don't select only for older horses. And now our test, the positive predictive value, is less than 5%. So again, what this means, ignoring the math, is that if you take this test and you don't consider clinical signs or age, it is very poor performing. And if all you do is pull an ACTH and look at it, you're more likely to have a false positive or a false negative than a true positive or a true negative. Did that make sense?
Yeah, that's really good information because people come in armed with their blood test, and a test is only as good as how you deploy it, right? And thank you for putting numbers to that and showing that, because I'll be straight, I find the blood work confusing a lot of the time because it does not necessarily fit the clinical picture, which you have emphasized, which is so important.
So when we looked at the pituitaries, it's pretty interesting. There's 5 grades, and I probably should have gotten a slide for that. I'm going to get rid of this stuff. I'm going to quit sharing so we don't have to look at mathematical numbers for too long. There's 5 grades to a pituitary. 1 is perfectly normal and 2 is perfectly normal. They're just slightly bigger if they're 2, but as a horse ages, their pars intermedia gets a little bit bigger. So 1 and 2 are normal. 5 is a big old tumor. So it can be like 5 times the normal size of a regular horse's pituitary. That's 5. That is clearly PPID. 1 and 2 are clearly not. 3, if you look at clinical signs, appears to be just an active pituitary, not diseased, just active. These are glands. They have jobs. And so the pituitary, the pars intermedia, is involved in change of season and metabolism and response to stress. So at times it's going to be active, and that's what a grade 3 is. The grade 4 is probably the first grade that is consistent with disease. But only about half of those horses that have a grade 4 have clinical signs of disease. So the pituitary changes are pretty far along before we see the clinical signs. And this is very true in human neurodegeneration as well. In Parkinson's disease, about 50% of dopaminergic neurons are lost before you see clinical signs. So it's not surprising in our horses we have all this change in this neurodegenerative disease before we see clinical signs.
That's very sobering because, you pointed out that part of the brain is integral for everything and pretty close to controls the functioning of that animal. And the changes are a long way down the road before we have any chance of seeing anything.
Well, you want to hear what I think is the most amazing thing? So I've spent 25 years looking at pituitaries, and I think they're beautiful. But one of the things that just blows my mind is if you see these grade 5 pituitaries, so a normal pituitary will weigh like 2.5, 3 grams. You can see these pituitaries weighing 10 grams. And the whole pituitary now is the pars intermedia, and it expands. And when it does it, it compresses all those other lobes that we looked at on that first slide. And from those other lobes are things like growth hormone, ACTH, that responds to general stress and drives cortisol, thyroid stimulating hormone, a lot of the reproductive hormones. So all these things come out of the other areas, as well as hormones that regulate urine output. And yet the horse has a fuzzy hair coat and is a little immunosuppressed, but is walking around when you know that this gland cannot be doing nearly half of what it should be doing. So to me, it's amazing that they can have as much change as they do and be relatively okay when you think about it.
That says a lot about Mother Nature and her ability to take the knocks.
Yeah, it's amazing.
Yeah. So you've talked a lot about the vagaries of diagnosis. You are driving up to this horse, you're getting out of your truck and you're having a look at it. What is your approach to the diagnosis of a horse, which you have a clinical suspicion in conjunction with the history the client has given you that this horse has PPID?
So the first thing is I really trust the clinical opinion. And so if I look at horse and it has some very subtle signs and the history suggests that it has PPID, I am going to believe it has PPID, even if my diagnostic tests don't support it. I may feel like I'm too soon in the progression, but the clinical signs, when you have the specific ones, and remind me if I forget to come back to that sentence, are pretty clear in the aged horse. Now, if I'm going up to a horse and it's young, I'm going to be far more suspicious that I don't have the correct diagnosis. But if it's older, I am very concerned. I want to check and be sure that there aren't other things going on in this horse, because the poor doing horse will look a lot like the horse with PPID. So we've had some rescue horses brought to us that just have not had good care, and they've had bad teeth and they're not getting good nutrition. And because they have a lot going on, they may be losing weight and muscle mass, and they often don't shed well. But once we get all of those things corrected, they start to bloom again and they look okay. So you have to be sure there's nothing else, that there's not a heavy parasite load, etc. But if you're pretty sure that you have PPID, then what I would recommend is doing a basal ACTH first, because if I have these clinical suspicions and a high ACTH, I have a nice clear clinical picture, and I'm going to move forward with treatment of that animal. If I do that ACTH and it's not supportive of disease, then we have two main options. Well, we have three main options, two that I like better. The first one would be, okay, we may be pretty early in the disease progression, and if it's just some subtle changes, we might give the horse a little bit of time and come back in 3 months and recheck it, because it's a progressive disease. And if the signs are subtle and nothing is either life-threatening or unsuitable for their job, we might have the luxury of time. The other thing that I would very likely do if we wanted an answer sooner is I'd move on to a more discriminating test, so a dynamic test. So I would do then the Trh Stimulation Test. Now, the tricky part of all the testing is that the pars intermedia's main job is to get the horse ready for winter. So this section of the pituitary gland turns on in the fall. And so the hormones go up quite a lot in the fall, and you need to use very specific reference intervals to know what's normal, whether it's not fall or fall. And you need to be careful, because we have learned that certain horses have really high fall increases without having PPID. And these are the horses that are of the breeds that are easy keepers or thrifty. My theory is that since the purpose of the pars intermedia is to get horses ready for winter when there's very little to eat, and they're kind of resetting their metabolism and growing a hair coat, if it's a horse that's really good at not eating, it probably has a really good pars intermedia. Now, that's just me making up pathology in the shower kind of thing when I think about stuff. So that's not proven. But what is known is that if you have ponies, Andalusians, Mustangs, and you test them in the fall, they're probably going to be way outside the reference interval. So you really have to look at clinical signs of the horse and the age of the horse before you jump on putting that horse on treatment.
You know, that's a really good way of looking at it. I've never heard it described that way, as its job is to get the horse ready for winter, but you're right. It's setting it up for a time when it's going from a land of plenty to a land of little, and it's altering its metabolism because of that. So that's a fantastically good way to look at it. So should you go down that pathway, you're talking about specific signs, and if maybe you don't get the answer you think you should get with a dynamic testing, where do you go next?
So it depends a little bit the clinical signs I'm looking at. So this is maybe a good time to bring up those specific versus not specific signs. One of the things, I think we shot ourselves in the foot with this disease, and when I say we, I mean a history of like 50 years. It's very confusing because we've been very confused. What's in the literature 20 years ago is not what we believe to be true now. And so we clumped a lot of things as being Cushing's disease that aren't really Cushing's disease. So the big fat pony with the cresty neck that's foundering does not have PPID unless it has PPID and insulin dysregulation. So we've learned that there's two separate conditions, but they can occur together. And so if what I'm looking at in this horse is obesity, laminitis, and maybe there's a little bit of top line loss, but the hair coat's okay and the horse is fairly young, and my blood work shows me it's not consistent with PPID, then I'm going to really focus down on this horse probably has insulin dysregulation and work on that, because you can lose top line from something like pain. So if the horse has been having pain in its feet, the pain causes weight loss. So there's other reasons for the weight loss. And I'm not going to put a horse on lifelong drug if I have other explanations and the hormone testing looks okay and nothing is specific to PPID. It all can be explained elsewhere. Just like if I had a horse that had a suspensory injury that was young and had other reasons and it wasn't old, I'm not going to jump on that. An exercise intolerant horse that's young. So I want to see a little bit more clinical evidence if I don't have support from the testing as well. So you got to think of the whole thing as a profile. The way I wish we had, similar to what we do with the sepsis score in foals, where we could put all of the pieces in and then come up with a probability that the horse has disease. We tried to do that. I know Hal Schott was working with it, and I think Frank Andrews and we put a bunch of cases together to try to see if we could develop a profile like that. But the problem was hair coat was such a strong sign that it just overwhelmed the profile. I think with the ability to now do more AI, where the machine learning can take over, there's an opportunity maybe in the future to gather some data and come up with a profile where somebody smarter than just a few of us kind of working up a profile, where a computer can actually take a lot of data together and say, oh, when we start to see these 3 changes, that's early signs of PPID. So going into the future, I hope we can get better at early diagnosis. Right now, the art of medicine comes into this disease so much, in that you really need the veterinary eye or a really good eye of an owner or trainer that's been with that horse that says, no, this is a shift. We haven't changed how we fed them. They're really not as thrifty as they were 2 years ago.
Yeah, and that's a great point you bring up about the progression, is that, it's not like throwing a switch, right? They're not sort of PPID one day after not being PPID the day before. It's a continuum, and you pick up on those hair coat changes. And yeah, what's helped me the most in some of them is, you're right, that hair underneath the chin and sometimes those long hairs down the legs. And you look at the rest of the horse and there's nothing going on. It says, hold it a second. You look like a billy goat. What is going on here? And there's no other signs that are obvious, but it causes you to raise your suspicion to look at those other things. And again, come back to that horse at a different time and sort of reassess things. So how would you treat these horses? Sometimes they have all these comorbidities, which sometimes would be extensive, but if we're primarily going after the PPID, what is the best approach? And there's more than one approach out there in the literature, because again, as you say, we've poorly understood this condition for a long time. What works, what doesn't, and what goes together well?
Before I jump down that rabbit hole, let me just say one more thing about diagnosis that occurred to me while you were chatting there. The other thing that we can use and leverage is, I mentioned that there's a huge seasonality in how the pars intermedia releases hormones. And we, for a while, said, well, you want to test in the fall because they're going to go higher in the fall if they have PPID. And then we said, no, don't do that. And we kind of waffle back and forth. But a horse that doesn't have PPID, any horse that tests negative in the fall, let's put it that way, any horse that tests negative in the fall doesn't have PPID, because that is when it's going to be at the most active. And so we always think of tests as having to tell us if it's positive or negative whenever we run a test. But if we stop thinking that way and we say, we're going to do a test in the fall, but we're only looking to see if it's negative, then we can use our test really strongly, because a negative test in the fall, whether it's an ACTH concentration or a Trh stimulation test, either of those being negative in the fall pretty well rule out that horse has PPID. So we have to stop thinking of our diagnostic tests only as being yes and no, and sometimes think we're just going to ask the question, does it not have disease right now? Or ask at a later time, we may come back and confirm it. So I just wanted to kind of circle back to that. As far as treatment, so there's 2 ways to look at this, and this is a little bit controversial right now. When we talk about testing, and I mentioned sensitivity and specificity, that has a lot to do with where you set your cutoffs on what you're going to call positive. So, for example, for several labs, they'll say anything over 35 is considered positive for PPID when you're measuring ACTH. There are new recommendations that say over 15 is considered, or under 15 is considered negative. There's a gray zone. And then over, I think it's 45 is considered positive. Where you set those cutoffs is a little bit based on whether you are going to be able to tolerate a false positive more or a false negative more. And that decision is, would you rather take a horse who doesn't have disease and put them on drug? Or is it more disadvantage? Is it more of a disadvantage if you have a horse that does have disease and you don't get it on drug early? So which one can you tolerate more? Does that make sense what I'm saying right there?
It does, yeah. Yeah, it makes a lot of sense, actually. What's the greater error, to treat when you shouldn't as opposed to not treat when you should?
And that is not an answer that's the same for every horse, for every situation, and every owner. But for me, when I go out, I wanted to lead it with that because I don't always use the cutoffs that are presented in either the consensus statements or from the labs. I will do a little bit of interpretation of that outside of those reference intervals. So if a horse is very, very low and the signs are very, very mild, and I still have a little bit of suspicion, I'm probably not going to treat that horse. We're going to make a plan to come back, or we're going to do a dynamic test. But if it's just mild signs, I'm not going to sign this horse up to be on lifelong drug that may or may not need. If the horse is a bit older, the signs are a little bit more conclusive, even if the test negative, that's a horse I might go ahead and put on Percend, Pergolide, because I think there's enough evidence. It's older, it's the right signalment, it's starting to show some signs. And we'd rather treat the horses early in disease, not when they're all long-haired like the first horse I showed. We know that if we can keep it from getting bad, we're going to prevent some potentially more serious complications than a little bit of hair under the chin. Mm-hmm. So the other option you have is to not treat the horse year-round if it's early in disease, but to just treat it when we know those hormones are going to be very active. There's not really good evidence yet to follow these horses to see how well this works over a long period of time. But if you have a horse that you know is kind of in that early phase of this progressive disease, you may elect to put them on Percend somewhere, maybe the beginning of July, maybe late June, and leave them on it, and then wean them off of it as they get into November, and just really try to keep them from getting super excessively high hormone concentrations in the fall. And that can help because a lot of the horses that are early will actually have pretty normal concentrations of hormones during April and May, March, those kind of months when it's at the lowest.
Okay.
I do recommend when you think you have it, I am a strong proponent of getting them on Percend when you feel confident. I just really don't know. There's an awful lot of horses out there on lifelong Percend that never had PPID. Maybe they had insulin dysregulation, or they just had something else. So I think that it is worthwhile to try to be pretty sure of the diagnosis before you jump in.
Yeah, I think that's a really good point, because we get a number of horses present to us because of the podiatry service here that have laminitis, and people sort of saying, well, the horse got put on Pergolide because it was foundering, when it's the other condition you talked about that confounds this, the insulin resistance, and there is nothing wrong with its pituitary. And all of that money and all that time has been spent going down the wrong road, and we still have clinical problems with this horse that never had a chance of being ameliorated because the medication was not right. So I think that's really valuable, like step back and look at the whole horse and don't necessarily get seduced by the lab work, and take a lot of notice of what time of year it is when you do your interpretation. So, and again, I think that's what I find my clients have trouble with. They think, oh, this is a yes-no test. It's going to work at every time of the year, and there's not going to be any differences whatsoever. And you've really well brought out the vagaries in diagnosing this condition and the subtleties in its appearance. And that's been really, really very informative. And so when you treat these horses, what responses are you looking for to make you feel that you're heading down the right road? And what sort of timeframes have you found in your experience it can take these horses to actually give you the response that you're looking for?
So the most important response that I'm looking for is the clinical improvement, more than the improvement on the lab work. And if I can go back, I'm going to share 2 slides because they're probably my favorite slides that I have from 20 something years of doing this. So what I'm looking for, this is a horse. And this was during a time that I had horses coming to me and staying with me at the university. This was a horse that was brought to me when I was in Oklahoma, came from Amarillo, Texas, I believe. So they drove pretty long for this horse to be in a trial with me. And they left him with me for 7 months. And when they came to pick him up, this is the horse they picked up. She was crying. She was so happy. So it is a disease that you can make a huge impact on. I have one more of these before and after pictures. This was a horse, Princess, that came to stay with us because she had laminitis, she had pneumonia, and obviously you can tell just by looking, see, there's that chin hair we were talking about, but she's got failure to shed everywhere. And then Princess promised, same horse. Now, okay, I will admit, one's in the winter and one's in the spring, so I'll admit that, but still, tell me your clients aren't happy when you can do that for them. So the first and most important thing that I'm looking for when I treat these horses is clinical improvement. That's going to take some time.
Those are impressive clinical responses. As you say, people would not believe that's the same horse, but that's incredible.
I promise.
Yeah, no, I believe you. Don't worry, I was looking for the white socks. They matched up. And so,
Yeah, that's Princess, and she looks amazing. And those are obviously my 2 favorite and best improvements. Yeah. So those horses had the works done. We got them in the beginning, and you need to approach these horses as an old horse that's debilitated because they're under the influence of a whole boatload of hormones. And so you need to be checking their teeth. You need to make sure that they're getting enough nutrition. And remember, they have a catabolic disease. So just because you've been feeding them one way for years, that's not necessarily what they need going forward. Be sure that they have fecal egg counts being done because they can be more susceptible to endoparasites. And then, of course, if you're going to take pictures, don't groom them in the first one and groom them a lot for the second one. But so you do want to take a pretty holistic approach, and to get the clinical improvement, to get the muscle mass coming back, to get the hair coat improvements, that's going to take 6 months or so. But you should see improvement in your endocrine testing if it was abnormal initially. You should see that really in a couple weeks' time. The ACTH starts coming down in 2 weeks. I'll usually give it a month before I'll recheck it. If the clinical signs are improving, the ACTH is going the right direction, I'm not in a rush to bump a dose up. I'll give it some more time. Again, this is slowly progressive disease. You're not going to just immediately whip the car around and go the other direction. It's going to take kind of the same amount of time to get it as it kind of takes to get all the way back. Not quite that long, but it'll take some time. So I do want to see the numbers improving if they were abnormal, but mostly what I want to see is that the horse starts doing better, getting some muscle mass back and having a better hair coat. If it has things like rain rot, is that improving? Abscesses. They're very susceptible to dental problems because they are susceptible to bacterial infections. So good dentistry, and then making sure that you follow through there. Sinusitis are common in these horses as well. And so that's the other thing. If you have a horse that still looks good, but is getting sinus infections or rain rot or any of those, and it's a slightly older horse, that's a horse I test as well.
All right. Yeah, taking care of all of those comorbidities, it's just so important to get those results that you had, which I'm still very impressed with. There's other, you get on Dr. Google or just historically, there's been other treatments that have been targeted at the PPID. Do you offer an opinion on the Cyproheptadine or any of the botanicals that have been used for this condition?
So Cyproheptadine, I know when I was back in practice, this is going to be like very non-scientific. Perlite wasn't very readily available back a long time ago, but Cyproheptadine was dirt cheap in the day. And so I know I treated some horses and they did seem to shed a bit, but that was the only thing that really seemed to improve clinically when we gave them Cyproheptadine. There has been some work done as a solo drug monotherapy, not effective. But and those horses that you've gotten your dose of pergolide all the way up to more than 3 milligrams, approaching 5, and you're not getting full response, you can add the cyproheptadine on top of it. I do not have personal experience of doing much of that combo to be able to say with confidence that it helps. Hal Schott, Michigan State, has done more of it and does. He has had experiences where adding cyproheptadine on top of the pergolide gives you a little extra boost on them.
Mm-hmm.
The botanicals are a little bit harder. Some of the botanicals have the same mechanism of action as pergolide, so they should work. The problem with botanicals is they're not regulated at all. So the first batch might work, and I can see logically why it would. If it has a dopamine agonist property, it should work. But absorption, the concentration of the active ingredient from lot to lot, if it's in any lot, none of that's regulated. And so the reason I think we see posts of some people saying it works great, and then other times it doesn't seem to work, is probably because there's not consistency in those products. The only study that I'm aware of that looked at it in a scientific manner was Dr. Jill Beach's at University of Pennsylvania. And in that study, chasteberry didn't work to improve the ACTH or clinical signs of the horses. And so to my knowledge, there's nothing out there other than Percend and really good management. And you can't downplay the management. If you have a client that doesn't want to put the horse on Percend because of expense, you can still get quite a bit of improvement on these horses by doing excellent care. So you need to be sure that you're making sure they're not getting infections, that you're taking care of that hair coat, getting it clipped when it needs to be clipped, really looking at nutrition and trying to be sure that you keep body condition score up, etc. So it's not unacceptable not to treat them, but it's certainly the preference would be to go ahead and get them on a dopamine agonist or Percend. And there are a couple of other new drugs that are being looked at, and there are some ongoing research projects, but I've not seen anything yet that's published that's conclusive enough to be able to suggest as an alternative. There is some compounding pergolide formulations that used to be available. I'm not sure how many of the pergolide type compounding formulas are still out there, because it's very clear that Percend's the safer way to go because you get the right amount of drug. There is one other compounded formula, and that's the cabergoline. And the only place where I would say that should be being used is if there is an absolute reason you cannot use an oral drug, because that's an injectable. Mm-hmm. So because of the fact that we have an FDA approved drug that's given orally, we should be using that when we are using an oral drug. But if there is a reason in a particular horse that you can't use oral drugs, then compounded cabergoline would be an option.
That's really good information. It clears up a lot of what's out there, because people come to us with some, again, Dr. Google, some very strong opinions on what works and what doesn't. And I think your comments on the botanicals are very, very informative in that we don't know what we're getting from batch to batch. And so while they should work, there's no guarantee that what you've actually got is going to work. Your elevator speech. I come to you and I say, I'm just a little bit worried about my horse. It might be Cushingoid because I don't know the proper term, PPID. What would be your first advice that you would give me?
Well, if you think it has changes, see, I'm not good in an elevator unless it's like the 100th floor. Sometimes that's so short. But if you are appreciating those differences in your horse, and you have been with your horse, you have the history, and you are seeing these changes, then I would definitely reach out to your veterinarian, because I think that trying to determine if your horse has PPID early on is the best strategy. And it really is something that the owner is critical. The history, the changes, what they're seeing is very, very important in the diagnosis. But then the veterinarian's eye, especially somebody who's not looking at the horse all the time, is also very critical. So I would say it is a disease where you can make a huge difference, as I showed in my 2 sets of beautiful pictures. It is a disease that is worth treating because many horses live very much 10, 15 years beyond the diagnosis and do very well and perform. And so I think it is worthwhile pursuing, having your vet out, having them take a look, going ahead and doing some diagnostics. And then if in fact the diagnosis is highly suspicious of PPID, if not convinced of PPID, then going forward with a plan that would involve using the pergolide as a primary pharmaceutical.
Diane, I think that sums it up really nicely. I'd like to thank you for coming on the Stallside podcast today. You have made a very complex issue much more palatable, and I think it's really going to help people understand the vagaries of this condition and how, it is a struggle to diagnose it, but once you get on the right pathway, you can really help the horses. And so that was Stallside for this week. We've been talking to Dr. Diane McFarlane from the University of Florida on the subject of what we colloquially call Cushing's, but is actually more correctly Pituitary Pars Intermedia Dysfunction, a complicated disease with a complicated ability to diagnose it, but very impactful for the horse. See you next time.
Thank you.